Welcome to VNA Lunch and Learn. I was looking, this is the first one we've had in person in 3 years. So thank you for coming, for those of you guys that are in person. And then certainly thank you for everybody that's on. The one thing we've learned during the pandemic is that hybrid works pretty well. So you can have in person, you can have virtual. So we have a number of people that are watching us virtually, so welcome to them as well. My name is Chris Kulak, Vice President, Chief of Strategy and Development here at the Visiting Nurse Association. On behalf of Catherine Krause, our CEO, and our senior staff, and everyone here today, welcome in person and certainly welcome online. So we will have a discussion today about our palliative care program, really about looking at the pilot that we participated in. We applied for that 8 years ago, I believe. And Jennifer Austin and a team of folks here at VNA did a enormous application. I believe it was like a notebook and a half for a Medicare pilot to provide palliative care. And we received that grant, or received that pilot notice. And I would argue that we probably outperformed all the other groups in that pilot and created what we think is an amazing program. And so today, Olivia Rogers, our Chief Nursing Officer, and Sarah Miles, who helped run that program, are going to come up and give you guys a look at how that pilot went, some of the outcomes of that, both locally and on a national level, and then really talk about how VNA is going to take that model, or how we have taken that model, and continue to provide palliative care, which is that precursor to hospice. So without sort of talking anymore, I'll ask Olivia Rogers to come up and get us started. So thank you again for being here.
Good afternoon, everyone. Good to see everyone in person and of course online. And really, I'm only here to introduce the very wonderful Sarah Miles, who ran our pilot program and then continues to be the director of our palliative program today. So as she will tell you, we're going to look back at what we've done, and then we're going to look forward at not only the future of palliative care at VNA, but also just kind of what we expect to see on the national stage. We're going to use different terms. Really, it's going to be supportive palliative care or community-based palliative care. These are kind of tricky words, and there's a really good handout that we'll refer to later that's at everyone's place that sort of looks at the difference between hospice and palliative care, which I think is a big question that most people have. So without further ado, Sarah Miles is the director of quality. She runs all of our quality performance improvement plans for hospice at VNA. And then when we first applied for Jennifer, even before Sarah and I were involved, was involved in applying, which was a huge undertaking for the pilot. We really, when you do these pilots with Medicare, you don't know how big it's going to be, how small it's going to be. We actually thought it would be quite small. And for all of our liaisons in the room and looking online, it ended up being huge. And so Sarah Miles was elected to run the palliative program, which we thought would be very small. And then it really exploded. So I'm going to let Sarah come to the podium. Sarah's a registered nurse. She and I were both case managers in hospice for many years. And then I'm the Vice President and Chief Nursing Officer. Nice to see everybody. And Sarah's the Director of Quality, but also the Director of Palliative Care. Can you get over?
Thank you all for being here. So, so if the VNA ever comes to you and say, hey, we run this really small program for me, it means they're going to give you a whole nother job. just so that you know that going forward. All right. So we're going to talk. There we go. So the mission statement for palliative care is to provide an interdisciplinary home-based supportive palliative care services. So that's a lot of words all at once. Interdisciplinary means not only is it just the doctor driving the plan of care, but it also takes into account what the patient wants, what the family needs, what the social worker can contribute to, and the chaplain for spiritual and emotional support. So it's not just the doctor handing out medications and going on their way. It's a collaborative approach. Palliative care services that we obviously provided were at home, and they were to meet these complex needs that we have for our advanced age, seriously ill folks. We all are living longer. hopefully we will also be living longer better so that we're feeling better into our age. And that's what palliative care is. We are going to get some serious illness, long-term diseases, and we need to maximize our quality of life while we live with these diseases. So the first part of my presentation is about the Medicare Care Choices model. We also called it MCCM for short. And this was the model that was presented to us nationally. It was presented, to hospices nationally, and they'd asked people to be a part of it. And the reason they decided they needed to do something is everybody knows Medicare is, the funds at Medicare are constrained. And so they were looking at the hospice benefit because the hospice benefit is a big money saver for Medicare. And they were looking at the beneficiaries and they saw that only 51.6, these were 2019 numbers, 51.6 of Medicare beneficiaries used hospice services at the end of life. So only half of all Medicare beneficiaries used hospice. And of those, only half stayed on for 18 days or less. So let me just ask you real quick, if somebody says you're going to die in 30 days or 18 days, is that enough to get everything in order, say all your goodbyes, see everybody, it's not a lot of time, 18 days. Especially then if you're not feeling well in those 18 days. So the goal of Medicare was to say, hey, I think we need to get people onto hospice earlier so that they can reap the benefits of hospice, of that emotional support, of that spiritual support, of all of those planning things that need to be done. So when you look at care without hospice, on average, and actually this is like a 2014-15 number, $32,420, and that was 7-8 years ago. The last 90 days cost a Medicare beneficiary about $33,000, $33,000, and it's probably closer to 40 now if you add inflation. So, and that's without hospice care. That's just going to the doctor, ERs, inpatient stays, and that kind of thing. Then, if you put them on hospice, that same patient, Medicare will only pay $15,000 because for those last 3 months. So you can see from a Medicare standpoint, they're saying at that point it's half. They're spending half that same amount of money, and the quality of life is generally higher. People generally do not want to be in the hospital. They do not want to sit all evening in the ER. They want to be home in their recliner with their dog, eating, their normal meals instead of hospital food. So length of stay in hospitals and length of stay in hospice is actually a direct correlation to quality of life. Oops, skip slide. Okay, so what Medicare said was, okay, if we give people hospice-like services, that access to that whole team, will we be able to improve their quality of care, their quality of life, and will we be able to save some money? And that includes the ER visits, the ambulance rides, the acute stays, the rehab stays, and all those tests and procedures that when you look at, it retrospectively, we do a lot of these procedures and x-rays and CT scans in the last 3 months of life that weren't going to make any difference and didn't really change the outcome or the treatment plan. So VNA had the foresight way back in 2014 when it was published nationally that they wanted to do this. They asked for applicants. And as Chris and Jennifer said, it was a big old book. And again, it's very vague what you're applying for. They don't give you the nitty gritty. They don't tell you how much they're going to pay you. None of that. They just say, hey, you guys want to be involved? And I know VNA, since the beginning of time, has always been community focused and healthcare advancement focused. Back in the 80s, VNA actually trialed what we now have as the hospice benefit. So this very much felt to be part of our wheelhouse. Yes, we all know Medicare needs help in how it spends its money. And if we can help get some data for them to do something a little bit different, we're happy to help. And so we applied in 2014. They had 2 cohorts. They selected overall 140 hospices. Cohort 1 started in 2016, and then we started in January of 2018. There was 82 active hospices by the time the program ended. So there was quite an attrition rate. That's because it was a hard program to run. There was a lot of data collection that was very time consuming, and it took full-time staff to do it. It wasn't something that you could just do on the side, as everybody was kind of led to believe, to do it right. And VNA always likes to do things really right. So the model was scheduled to end in December of 2020. However, a pandemic. So I think that led a little bit to their decision, because it was just a hard time in healthcare. But more importantly, they were seeing the numbers that they liked. They were seeing that the program was a success. And so they extended it one more year to just gather one more year's worth of data, and just kind of bolster those numbers. Also to see how those numbers were affected through COVID. So we had the option to bail out in 2020, but of course we said, no, we love this program. Our community loved this program. Like Olivia said, we thought at the beginning, if we get 30 patients, over the 4 years, we will have done awesome, because we just thought it was going to be such a struggle to get patients. And we had 30 patients in the first 30 days. We had to turn people away. They were coming so fast because there was such a need. So it was really exciting for us to be a part of a model that not only showed that it was working, but was so well received by the community. So, and I have a caveat on a later slide. Our data that we gathered here at VNA was very consistent with what the national data was. So the next couple of slides, I'm kind of a data nerd, because it kind of tells the story. So, and if I go too fast, please slow me down, because there's just a lot of data, but it's exciting numbers, and the numbers tell the story. So I thought we needed to go through them. So one of the things that, so there were 6,427 by the end of September of 20 that had enrolled. Of course, then they extended it for another year and a quarter after that. But through the end of 9/30, that's where we were, of 9/20. And 83% of those people eventually transitioned into hospice. And we, along that line, we were very similar. We were like at 81%, 82%. So we were very consistent with that. There were only 4 diagnoses that were allowed into the program: heart failure, CHF, COPD, chronic obstructive pulmonary disease, HIV or AIDS, and then cancers. And they had to be fast, super slow growing cancers didn't make it, but most cancers did come in. They did need to have a terminal prognosis of 6 months or less. Of course, once you got into the program, if you outlived 6 months, that was fine. You had to be living at home or in an independent living setting. They did not allow us to take anybody who was at a residential care home or an assisted living or in a skilled facility, because the Medicare felt those people had a little bit more access to health care, and they were really kind of focusing on people out in the community that had limited resources. Okay, that's how I know when the tongue gets sticky. And then they also had to have traditional Medicare insurance. So we, over the course of the 5 years that we did it, we received 724 referrals. We enrolled 370 patients, and our average daily census was about 45. Sometimes it ran up to 50, but hung around 45. And you'll see that our length of stay was about 140 days on service with us, and the national average was about 135. So we were really close to the main numbers that we saw. Okay, so what happened to our patients, once they left our model? Now, this graph is based on our final exit numbers, not during the middle, because during the middle of the program, we saw that about 80%, 82% of people were transferring to hospice. This shows it's a little bit lower because at the end of the program, we had to stop it, and those people filled up the revoked section. So the numbers skewed up a little bit. But overall, through the course of the whole program, we had 61% that transferred to our hospice, and then another 9% transferred to somebody else. And they did have that choice. You did not have to come on VNA hospice. Your hospice choice is your choice. It doesn't have to be influenced by who you're receiving care from prior. 10% did die on service. And I know that's sad, but actually it's a good thing. And here's why. Because if you died on the model, on the Medicare Care Choices model, you still received the benefits of our bereavement counseling program. So these were people who normally, if they had just died in the hospital or died at home without hospice or palliative care, it just would have ended there. But we were able to come in, as part of our requirement was to come in and follow these people as well after death, just like we do with our hospice patients. 3% moved, and then again, 16% revoked. Most of those were because at the end of the program, we just had to discharge them out because there was no more program. And then some of them did revoke because they were, not because they were unhappy, it's because we made them better, which is always a bonus. We love it when that happens. It's like graduating from hospice. Okay, so what we saw was there was a 14% lower Medicare A and B expenditure. Medicare A is hospital, and then B's all your doctor's visits. We saw 26% fewer inpatient hospital admissions. And that's a significant number. That's a quarter less than normal. And if you've ever gone into the hospital for just a day, it's not cheap. I mean, those bills rack up really quickly in just 24 hours, let alone a 3 or 4 or 5 day hospital stay. And then we also had 14% fewer outpatient ER and observation stays. The reason for that is because with the model, the nurses, they had access to 24/7 nurse care. So we taught them, instead of going to the ER, because a lot of people, that was kind of their mode, right? I don't feel good, I go to the ER if it's not between 8 and 5 and I can't get to my doctor. We trained them, no, call us first. We will come out, we will assess you, we will order the meds, we'll call your doctor after hours to get through that phone tree system. We'll call our doctor if we can't get your doctor. We'll do anything to keep you out of the hospital. Now, if you need to go to the hospital, we will help pack you into that ambulance and get you on your way. But we wanted to give them one more layer before they ended up in the ER. And I think you can see these numbers absolutely prove that just having a relationship with somebody you can call when you're not feeling well will keep people out of the ER. So again, I said these are very number heavy slides. So per enrollee, Medicare saved about $7,500 per person, and all enrollees together combined to save $33.2 million. So that's a significant savings. There were 39% lower inpatient expenditures, 22% lower skilled nursing, people going to rehab was lower, and then 22 other expenditures, ambulance services, ER visits, physical therapies, and that kind of thing. So, numbers are great, but it's all about quality of life. And again, we correlate length of stay and hospital visits with quality of life. Again, because people don't normally choose to spend their days off in the hospital. So you'll see that there was people who received what's called aggressive life-prolonging treatment that isn't really helpful. There was a 26% decrease in that. There was 4% more days at home. There was 21% decrease in emergency department visits, 45% decrease in multiple hospitalizations, 46% decrease in ICU admissions, which is a significant number, and 54% decrease in the amount of people who died in the hospital. So for people who elected hospice from the model, we saw that they were 43, and these are from the statistics published from the Medicare Choices model. People who were compared to just nationally, people in the model are 43% more likely to elect hospice. And they will spend 126% longer on hospice than they would if they hadn't gone through the MCCM program, through the palliative care model. So we increased those 18 days on hospice way up. And then they had 13% more days of hospice benefits. Oh, I went the wrong way. I'm so sorry. All right. So you'll see here, traditional care without palliative care, you spend out of the last year of your life, you spend 347 days at home, going into the hospital, seeing your doctors, going to the ER, going to the ICU, all that. And then you spend the last 18 days here on hospice. With the Medicare model, 184, about 6 months, you spend doing your normal living and seeing your doctors. Then in that period, that last 6 month period, 140 of those days people spent on palliative care, where we saw all the decrease in needs for all of these extraneous services. And then they spent 41 days on hospice. So doubling the amount of time on hospice than the national average, which is about 18. Okay. So we were excited we knew it kind of in our heart when we looked at the program. Yeah, this should work, right? If you give people access of someplace else to go besides the ER, help them in their home, because I don't know about you, even when I go to the doctor, you know, I know I'm a nurse. I have my little list on my little note card and I ask my questions. They tell me, I go home and I completely forget everything that the doctor said. And, you know, and I'm only 50 something, you know, let alone my parents who are in their late 80s, you know, they don't remember anything that the doctor said and they don't remember the questions they asked. So it's really hard when you go into that environment and it's new and different and you can't learn anything. You learn better at home. That's when the nurse is there. She's looking at your bed. She's talking to you about this pill bottle right here that makes sense to you because you know that's your heart pill. You know, you don't know the name of it, but you know that's the bottle it comes in. And that's why we can make a difference, is because there's that at-home care treatment. And we knew that that was going to work. We know it because we used to do home care, and we know it because we did hospice. And that's where the teaching, the learning, and the trust is built. So we are excited that the data supported the proof of concept. You know, Medicare told us these were the goals, and from the very beginning, we saw that we were making a difference because we were getting the calls to come out and see us, and we knew we had just prevented an ER visit. And we learned through that it's worth continuing. It needs to go forward because this does save money. It does provide a very positive impact for our community. And this is why we're very uniquely qualified to take this kind of program, modify it because there were constraints on the model that we don't want to have. We want to open it up broader and bring it out to the community. So that's the look past. We learned that patients and physicians are looking for alternatives to hospice when they're not quite feeling like they're ready for hospice. Because right now you're either full on going for care or you got to be on hospice. There's no in between. And people feel like, well, I have to be dying to be on hospice. You don't, but it's hard to convince people of that because most of the time when you hear about somebody's on hospice, they die within a few days. And so that's the general concept of what hospice is. We need to, as a provider, we need to do a good job of educating our public. No, that's not what it is, but we're not there yet. So in the meantime, we support people in this palliative care scenario that they would not have gotten in any other way. We get them emotional and spiritual support. When you're facing a serious illness, it's not only emotionally crushing and disconcerting and depressing sometimes. So there's all this emotional component, but there's a spiritual component, like why me? Not just actual faith-based, but just the questions about life itself. And why is this happening? How do I deal with it? And that includes the family as well. There's lots of planning that needs to be done that a social worker can help you with in terms of okay, I can do this today, but what happens when I can't do this anymore? Where am I gonna go? Who's gonna take care of me? Who's gonna pay for all that? How do I express those wishes? All that seems to be very complex the older you get. It's easy to think about it when you're 20 because you're like, I'll live forever. But you know, when you hit 50, all of a sudden that gets a lot closer. So, you know, we also learned that people don't want to go into the hospital. If you give them an alternative, they will seek that alternative, which is very exciting. And one of the things we noticed was when our patients on palliative care were ready for hospice, 9 times out of 10, they came to us and said, I think I need hospice now. I'm ready. Versus us telling them, you know, you really need a hospice now. You're really going down. They knew because of what we were teaching them and we were educating them about their disease process, that this was part of what's coming and the decline, and they were able to recognize that. So more often than not, they were approaching us and it became their decision versus a decision that was kind of made for them. Like when the doctor says you need hospice, you know, that feels very abrupt and kind of condemning for a lot of people. But when they were on palliative care and then they came to us saying, I think I need hospice now, that transition was much more smooth. It was not the big day that it usually is for a lot of people when we sign our loved one onto hospice. You know, that is kind of a hallmark day where we have now, you know, embraced the fact that this is, you know, we're on the end of everything. And so we were really encouraged about that because we want people to be on hospice and we want them to feel like it's their choice and their decision to do that at that time. And I felt we really did a good job of getting our enrollees into that mind frame. Okay, so next we're going to talk about what we want to do in the future. So based on all of that good information and all those positive numbers, we just want to keep doing good things. And so we are looking at providing home-based supportive palliative care. And one of the things I tell people is palliative is kind of this new buzzword in the industry. If you look on the news, you look at palliative, I do palliative, everybody does palliative. I can hang a shingle on my, you know, house in McKinney. I do palliative, and anybody can do palliative. Hospice has a capital H. And if you think about it this way, hospice has a capital H because Medicare says when you choose hospice, these are the things you get. You get a nurse, you get a doctor, you get a social, you get a chaplain. We pay for your medical equipment. We will pay for these meds. Okay, it's very clear what hospice is. Right now, palliative has a lowercase p. Like anybody can do. I can call you once a year and say I am palliating you. I mean, it's really loosey-goosey right now. And so what we're hoping and what we're working very diligently with the state and with the national organizations is to define palliative care so that when I say I do palliative care and they say they do palliative care, you all know we're talking about the same thing. Because right now it's very variable as to what that is. So I'm going to describe what VNA wants to do with our capital P palliative care program. If I can get it to go. Okay, yeah. So we found from the MCCM study that the target populations that they had were really good, but we also saw that there were some other populations that were not served that would really benefit from serious illness management. So again, COPD, obstructive pulmonary disease, heart failure, cancer, but we also saw people with liver failure and pulmonary failure that didn't fall into those other categories really would be helped. So we're going to expand our diagnosis criteria. There's some reasons that we don't do other disease processes, and that's because of their trajectories are very difficult to manage, and sometimes there's the only thing to manage them is to go into the hospital. For example, end-stage renal disease, dialysis is the fix for that, and I can't dialyze you, and VNA doesn't do dialysis. So if you get really sick, you need to go into the hospital, get dialyzed. So VNA isn't going to do, isn't going to work with that population because they have a different set of needs. But these people have the needs that we can meet in their home. So Our goals are obviously prevent unnecessary hospitalization, provide expert symptom management. You'd be surprised how, many of our loved ones have several doctors, but the doctors aren't speaking. And so they have these meds from this doctor and these meds from this doctor and these meds from this doctor, but nobody's looking at the whole picture and saying, okay, do you know what these meds are for and why when we take them? So we, being in hospice, that's all we do, symptom management. We make you feel good all the time, or as much of the time as we can. So we're here to help you focus on your symptom management, making you have the highest quality of life you can, given the illness that you have. We're going to educate you on your disease process. Again, not a lot of disease process education happens in the physician's office. They just don't have time to go over it over and over and over. Also, if they told you, you probably would have forgotten anyway by the time you got home, or you would have locked onto the worst thing you heard and everything else goes by the wayside. So again, having somebody that can talk to you, over time and educate you about what to expect. What does this look like? What do I do when that happens? Again, we talked about medication review, so important. So many issues out there can be handled by better medication review and management with our patients. Again, we provide emotional and spiritual support for these families. I don't have an exact number, but I'm sure I could find it somewhere. But there is, just anecdotally talking to our hospitals, there's a lot of people that go to the hospital, not because they're sick, but because their family broke down. Nobody could care for them anymore. They bring grandma to the hospital because they're done. They can't figure it out. Everybody's done. And she shows up at the ER, and then the hospital spends the next 5 days trying to figure out, where am I going to put this person? This is the kind of program that can help that, because we're going in before the crisis happens and saying, okay, it looks a little rough in here. What can we do to help manage this situation? What services can we get here for you that can help you keep her here longer? Or do we need to start talking about moving her, and let's help you find someplace that's affordable? Coordination with other doctors and clinicians. Everybody's going to see 17 different people, and sometimes they need help to know who's the most. If I only can make one doctor's visit of my 5 this week, I'm just thinking about my mom, so because she's like this. If I only have energy for one, who should I go see? Not the podiatrist. Okay, go see your heart specialist. He's the one who needs to see you this week. We will reschedule the podiatrist. Some people, though, they don't know. They're all important to them. I mean, getting my toenails fixed is just as important as my heart, but we can help them say, okay, this is true. They're both very important, but, and then we go and explain why we need to do this week, and we'll reschedule the other one. You would just be surprised at how overwhelming all of these specialists are for our community. Again, there's also a lot of facilitation between the doctor and the patient to the doctor. Our doctors love that there's somebody in the home telling them what's going on, because the doctor only knows what the patient tells them when they're in the physician's office. But oftentimes when we get home, it's a completely different story. And so we're able to report to the doctor saying, hey, the reason maybe their blood pressure medication isn't working really well is because they're drinking 17 sodas a day that has all this caffeine in it, and it's bumping up their blood pressure. Or the reason their diabetes isn't well controlled is because there's a 2-liter Coke next to their bed, So the physicians appreciate that because they get an insight into the patient. And then the patients feel like they have a better connection to their doctor because the nurse is calling for them. When we call into our doctor's office, it's, press 1, 2, 3, 17, and then you may get somebody, chances are you'll get a voice recording, and then who knows when they call, and then when they do call, we're never pick it up, and it's very hard. But when we call, we're allowed to push the nurse number, which is a special number for nurses, and we get through, which is really exciting for them. They feel like that's a much more immediate connection and immediate service with their physician, and gets their questions answered. And then finally, what we really want people to do is to talk about their advanced care planning, not just their advanced directives, but the whole process. What are we going to do when this happens? And then what if that happens? And what if that, have it all lined out, have those discussions with the family so that we understand what the plan is, so that when it all does happen, or if it happens, everybody's on the same page and it's not as scary. We don't want it to be a source of frustration. We certainly don't want families being divided because these discussions weren't had, but we know families won't often bring those discussions up themselves because that's awkward, right? Mom, Dad, let's talk about your dying. Nobody does that, we should, but we don't. So we come in and say, hey, let's talk about options here and just getting a feel for that. And so we can help with that goals of care, finding out from the patient, what are your goals? Do you want to go to the hospital or do you want us to do everything we can to keep you home? Clicking. Okay, so we are going to have a team approach again. We have the patient's primary physician or specialist is still going to kind of run the show medically. And we also have our palliative care physicians, and we have a nurse practitioner as well that can do patient visits in their home if the patient can't get to their other physician. We have an RN case manager who will be their primary point of contact. We have a social worker, a chaplain, and then all their meds are also reviewed by a pharmacist as well for any things that we should be looking for or contraindications or things that we just need to watch. Okay, so right now we are looking for reimbursement sources. Medicare has not come out and said, we're officially going to do palliative care with capital P, like we do hospice. There are rumors floating around that there will be another Medicare model reinstated because it worked so well the first time that they're liking the idea of doing it again. But that won't happen for at least 2 years because they don't move very quickly over there. They're still running through the data and it'll just take them 2 years to get that. I have a very strong feeling though, the second they put that flag up, we will be the first in line to sign up again. But we're looking to contract with managed Medicare, private insurance companies, managed Medicaid, hospital system, and accountable care organizations, ACOs. So that's all I have to say about that, which was kind of a lot, I'm sorry. Just so that you know, I have references, I didn't make it all up. And, and then we also have, for you, who are super data nerds, I have a lot of appendices where, we show a lot more of the data that we got. So that's it. Do you all have any questions for me? I'm sorry, I'm a fast talker. So if I need to go back to a slide or something, let me know. Yes, sir.
One of the things that I think we all think about at some point or another is the Alzheimer's dementia.
Right.
How does that fit into it? What I understand, there's really not much you could do, but someone's got to take care of that person,
Right.
which could put an extra pressure in your household.
Right.
So would be that palliative or is that hospice? You don't know if the person's going to die yet.
Right. So the reason that in the original model that Medicare did not include Alzheimer's is because for most other disease processes, it either, so cancer goes like this, okay, you're doing okay, you're doing chemo, you don't feel great, but you're pretty functional, and then you get really sick kind of really fast and decline from there. For heart failure and COPD, it's a stair-step approach. You have a little incident, you kind of decline, you might get up better a little bit, but then you have another incident, you decline, you never get really back up to here again, and it's kind of a slow stair. The problem with Alzheimer's is it's so incremental. Some people do this, but most, it's very slow. And it's really hard to know where you're at. Some people, it takes a year, some people it takes 10 years, and they're in that same space. And it was really hard for Medicare to say, you're in this section of Alzheimer's disease, because we've all seen people who who have Alzheimer's many years. And their skin and their bones, and they last 3 more years beyond that. And you would think at any one point in that time, okay, they need to be at the end, and they still aren't. And then you have people who look very healthy, and all of a sudden they get pneumonia one day and they die. And so that's why they didn't include it in the model, is because it's just really hard to pinpoint for their statistical purposes. Where are we in that? Because they didn't want to skew the data, you know, with too many long lengths of stays. Additionally, part of the rationale was generally those people are in some kind of a care situation. You know, I know many people are caring for their Alzheimer's patients at home, but when they get to that full-time 24-hour observation care, they are placed into a memory care unit. And so they felt that those people had access to, you know, medical observation and services and that kind of thing. Additionally, those people are not the ones necessarily that do the ER revolving door as much. They do, but it's usually for falls. And, you know, they have to get their head stitched and they come back and then they fall again, or they have a UTI, which is a quick ER visit. So though the way those patients are managed is very different than how those other diagnoses were managed. Ideally, yes, there would be something like that, because I think there is a lot we can do for that population. It would, but the structure would need to be different because their needs are just different enough. And most people that we see, if they have Alzheimer's for any length of time, they also don't have these other life-limiting conditions, because usually if you have a life-limiting condition, you die from those first before the Alzheimer takes a long time. Does that make sense? Yeah.
Talk about how you would know though when someone's appropriate for hospice, which is available for Alzheimer's.
Right. So Medicare is very clear as to what makes you your Alzheimer's, dementia, senile degeneration population appropriate for hospice. There are scales that they use that you have to meet. And when you no longer can control your bowels or your bladder, that's one of them. And when the patient is starting having trouble walking purposefully, and it's hard to describe, but for example, I happen to have a problem with Diet Dr. Pepper. And if I'm sitting over here and I'm talking to Olivia and then I go, oh yeah, okay, I do this without even thinking about that. But now if I have dementia and I'm sitting here and Olivia says, Sarah, go get your Dr. Pepper. I know how to walk, I just did it. But now that I have to think about it, I can't make my body do what I need it to do. Okay, and that's at that point is when we're hospice appropriate, because we've lost that ability to be kind of independent and think through the things we need our body to do. Does that help? So again, if you're having trouble toileting, that's also part of the neurological process, is being able to control those impulses and pause those impulses. If we can't do that any longer, and then we're struggling with walking or saying, words that make having an appropriate conversation. For example, if I say, how are you? Okay. If you ask somebody with advanced dementia, how are you? They're going to say fine, because they're not thinking that word. We have said fine our whole life. And so that is more of a reflex now than it is a thought. If I said, what did you have for breakfast today? Now it's an open-ended question. Now we need to think and remember and have purpose. Okay, so when we're evaluating people with dementia, it's not just can they say words, because we can all say words. Can they think them through and have a purposeful answer? Okay, so of course there's many layers in that, but that's kind of, if you've got a loved one who's kind of at that point, that's what we need. That's the criteria we're going to be looking at. Any other questions? No? You're laughing at me. Okay. Yes, ma'am.
How do we talk to our doctors about?
Okay, so right now, there's hospice, there's palliative care that is offered in outpatient clinics. There's doctors who will palliate your symptoms. And a lot of that is expressing to them what you mean by do you want me to cure me, or do you just want me to make me feel better? Okay, because they're not necessarily the same thing. Sometimes curing you of a problem gives you more medicines that make you feel worse, but overall it's going to cure you. But if you're to the point where I don't care about living longer, I care about living better. And so I want the medicines that maybe I'll stop taking that heart medicine that's going to make my heart a little bit better, but my appetite will be better. I won't be depressed. You know, there's some medications that have significant side effects. And when you're looking at the purpose of quality of life, that's when you need to talk to your physician about, okay, I understand I'm at this point in my disease process, and are there things that we need to do to just make me feel better for however much longer that I have? So there's palliative care clinics in hospitals. There's if you go into the hospital and you have a serious illness, most hospitals now will give you a palliative care consult as well. There's physicians who do it at home, and then like we said, we're going to be doing it too. But when you do, look out into the community and you Google, who gives at-home palliative care, you really need to be asking some significant questions as to who's on the team, how often will they come and talk to me, what services are provided, because you'll be surprised. Sometimes it'll be the social worker will call you once, and that's their palliative care program, or it'll be you get an entire disciplinary team. So you do need to really do some investigation, because again, palliative care is a little loosey-goosey right now, and it's not well defined. So you need to investigate what services are you actually offering me so that you can compare apples to apples. Did that answer your question? Okay.
We have a question from the chat.
Okay.
Can you talk a little bit more about, did Medicare keep track of any out-of-pocket expenses for beneficiaries and what that might be, or was that part of the overall expenses that were saved? And then maybe talk a little bit about what's covered under Medicare hospice benefit.
Okay. So for the Medicare Care Choices model, they didn't talk about, they only looked at the Medicare money, Medicare billing, because that's really what they had control over. So if you paid extra for medications or your Part D, or that wasn't included in their final calculations. However, you can extrapolate though that if you didn't go to the hospital and have all this money spent, you probably didn't also spend all this money either, because there's deductibles and co-pays and those extra expenses. So what's covered under the hospice benefit is it's pretty all-encompassing. So if I have a terminal diagnosis, say of heart failure, everything related to my heart failure and any diseases that would contribute to my heart failure. For example, I have heart failure, and it's because for all my whole life, I've had hypertension. So anything related to heart failure would be covered under the hospice benefit. Anything related to that hypertension, because that's a comorbidity, would be related to that. Anything, or any diseases that is going to also affect your length of life and quality of life is going to be covered. So what is included is the services of your entire interdisciplinary team, your VNA hospice physician, your nurse aide. We provide a home health aide to help with bathing and dressing. We have chaplains, social workers. We have a fantastic volunteer program that will come in and visit with you all. We have child life specialists as well for our families who either have a pediatric patient that's on service, or for families whose parents might be on hospice but have young children who are learning to come to cope with what are we going to do during this. So you get that whole team. The hospice will also pay for medical equipment that you might need. For example, your oxygen, if you need a hospital bed. A lot of people want to stay in their own bed for as long as possible, and I get that. But at some point, having a bed that sits up and lowers down and has rails is really beneficial. So we'll provide a hospital bed. If you need a wheelchair, a walker, a shower chair to get in and out of the shower so that you can do that shower seated, all of that equipment is provided. And then medications. So for example, if you have glaucoma, that's not related to my heart failure or my hypertension. So that will go under your Part B and get paid normally, how you ever do it through CVS. But all of my heart medications and my Lasix and everything that I'm going to need to control these symptoms, we're going to pay for. And the beautiful thing about VNA is we have a contract with pharmacy that will bring it to your house. So you do nothing. You just talk to your nurse and she says, yeah, we'll get that ordered, and they deliver it later in that day. So did I forget anything about what hospice covers? Pretty much it. Yeah. Yes, ma'am.
What is the current amount that Medicare pays for hospice per patient per day?
So it varies. It's upwards close to about $200, not quite $200 a day. And then that varies a little bit because if you're much sicker and you need a higher level of care, hospice actually provides 4 levels of care. The vast majority of people are on the routine level of care at home, which is at $200 a day. And then there are much higher reimbursement rates for people who need to go to a general inpatient unit because they have symptoms that can't be managed at home. Or they need a 24-hour nurse at the bedside because they have symptoms that are out of control. Or if the family needs a break and we can put a patient in respite for 5 days. So let's say, I'm going on vacation and I can't take care of my mom, they can go into respite. So those higher levels of care reimburse at a higher rate. And then it varies around the country, whether it's rural, it has to do with the wage index and all of that. But for us, it's about $200 a day. But Medicare, like Sarah said beautifully, Medicare expects out of that umbrella of $200 a day that virtually all care for that hospice patient is paid for out of that $200 a day. What we're looking for and we're really lobbying for is for Medicare to create a permanent supportive palliative care benefit where people don't have to choose between aggressive treatment in the hospital and that kind of revolving door as people get sicker, or hospice. There has to be some middle ground where I have a serious illness and need care and need advice and need someone to oversee my care, but I don't want hospice. And that's where the gap is right now.
Because on hospice, hospitalizations are not covered under the hospice benefit because we're supposed to be managing everything at home. So Medicare does not like to see somebody on hospice and then they go to the hospital because then they question the hospice. Well, why didn't you take care of this patient? Now, obviously, if you fall and you break your leg and your bone is sticking out, yes, we will take you to the hospital. Medicare understands that. But if I go in for shortness of breath because I can't breathe, they're going to wonder why the hospice didn't take care of that. So when you have people who are kind of in that, they don't feel like they're, sick enough and they might want to go to the hospital. Well, then, they're not appropriate for hospice because, hospice, we're really supposed to keep you at home. But yeah, we don't want them going to the hospital all the time. And so they would benefit from an intervention like palliative care where just in case, that is an option. However, let's work to keep you at home longer. That's a good question.
The handout, I think, and this is from the National Hospice and Palliative Care Organization. I actually used this recently for a friend of mine who's was trying to decide whether to choose hospice or palliative care for her father. So this is really, really helpful when people are faced with these decisions. And the website is actually the National Hospice and Palliative Care Organization, nhpco.org. And there are references like this for all kinds of questions having to do with end of life or serious illness care called Caring Info. So it's at the top of this, but you feel free to go to that website because it is great if you have family members or friends who are having to make these decisions. It has so much good reference material.
Yeah, sure.
So is the VNA going to wait for the 2 years for Medicare to approve payments? Or is the VNA currently providing palliative?
We are planning on providing it in the interim. Yes, as a, in the stop measure, because if we waited for Medicare, they say 2 years, but
Would be
yeah.
supported by donations or?
Well, we're looking for funding sources as well. Yes, that's that whole team's job back there is to find us some payers. Yes.
We're hoping to launch, and I know this was a question that had come up, we're hoping to launch this fall our supportive in-home palliative care program. And we are working with some entities to develop contracts, payer contracts, which is tricky. And a lot of people are looking for those, but that's where we are right now. If Medicare comes up with another pilot, we will apply for sure. And I don't know if you said this, but We were also noted to be an exemplary
Yes.
provider of MCCM, thanks to Sarah. Medicare contacted us at the end of the pilot.
In the
gave us-
middle, at the middle and at the end.
Middle, and said that we were an exemplary hospice, so I think they would allow us to do it again
Oh,
gladly.
yes.
So we would definitely take advantage of that, but we do feel because the community need and our marketing liaisons can tell you, the need is extraordinary. We still are getting calls every day wanting palliative care, and so that's why we decided it was a good idea to go ahead and launch. Right.
Okay. Thank you all so much. I appreciate y'all.